one is Dr. Standaert, who's going to speak to us. He is from our own rehabilitation unit and here with our special spine group. Dr. Standaert.
Thank you, Ted. Hi, I have a much more focused topic to go over. I'm going to talk about sacroiliac joint pain. And this sort of bridges a bit between the systemic arthritis population, the more general population of patients with low back pain that a lot of us see on a routine basis. I'm on this one. So we're going to talk about workup and non-operative management. I'm going to go through a couple of things. Briefly about anatomy. I'm going to talk some about epidemiology of SI joint pain. I think it's somewhat misunderstood and misquoted frequently. Then we'll talk about how different factors in diagnosing sacroiliac joint pain and some concepts and data on management, what our management options really are. If you look at the SI joint pain, it's the SI joint. It's a diarthrodial joint. There are irregular joint surfaces on both sides, hyaline and fibrocartilage components to the joint. The joint itself has a fairly rudimentary posterior capsule, but a broad ligamentous system of ligamentous supports behind the SI joint to provide stability. When we look at the innervation of the SI joint, which becomes quite relevant when we start talking about some of the different treatments, the innervation is really debated, and this gets difficult when we start talking about, again, some of the treatments people are trying to apply to the SI joint. There's thoughts that the posterior innervation comes from the dorsal rami of anywhere from actually L3 to S4, different disagreements amongst different authors and researchers. Anteriorly, the ventral rami from L2 to S2 may provide sensation. Some authors have suggested the superior gluteal nerve and the obturator nerves also provide sensation to the joint. Regardless of the sensation, certainly given all the innervation of the SI joint clearly is a potential pain generator and clearly can be a cause of low back pain. We get into treating and working with patients with SI joint issues. A couple things come to mind here. One, no muscles act directly on the SI joint. So there isn't a muscle sort of works across the joint that you can rehab directly in that manner. The motion of the joint really is quite limited. Normal individuals, 2 or 3 degrees of rotation, about 2 millimeters of translation of the joint, so very small degrees of movement. And I think really there's a legitimate question that's raised in literature about whether you can really appreciate abnormalities of motion on physical exam, given the very limited degree of motion the joint truly has. If you look at the epidemiology of SI joint pain, I saw these numbers getting ready for this talk. I just picked up a few more reviews of various things, and this number is a number you see quoted a lot. About 30% of patients with chronic low back pain have SI joint pain. And that really isn't an accurate statement, I don't think. If you go back and look at some of the studies establishing the prevalence of SI joint pain, there are several studies that use a double block protocol. They block somebody once, they do well, the pain goes away, they block them again, and see how many of these patients actually seem to have SI joint pain. The numbers in these studies are really in the 10 to 20% range. And one of the important things to understand about these studies are that they're really on patients who have suspected SI joint pain to begin with. So these studies are 10 or 20% of people who have pain that's clinically felt to be related to the SI joint. And there's a study by Mankincati where they followed a sequential diagnostic block protocol of all the patients who came into their center for, really came up with about 2% of their patients who came in for interventional care for low back issues had SI joint pain. I think that's really getting much closer to true prevalence. I don't think it's a very common problem. It's certainly not 30% of patients with low back pain. Diagnosing SI joint pain can be difficult. Generally, we think of SI joint pain from a clinical perspective as presenting with buttock pain. It can cause some degree of radiation to the leg. This is a map from Fortin where they stimulated the SI joint and sort of saw where the pain went to. Can radiate down the leg some. We certainly see it in the seronegative spinal arthropathies. Chu et al. Did a study, a retrospective review of their patients who had been injected and tried to break them down as to what the etiology of the pain was. Traumatic repeated stress were the majority, some idiopathic. If you look at diagnostic issues in physical exam, there are a large number of physical exam maneuvers described for the SI joint. A lot of you are familiar with a number of these. Ganson's, Patrick, Gillet's, a bunch of palpatory techniques. The trouble we have with these, though, is that if you look at a number of studies that have people examined, they go through all the different diagnostic techniques, then they block the joints and see whose pain actually went away. And does that correlate with who was thought to have SI joint pain based on exam? And really all these provocative maneuvers are really not reliable in diagnosis and do not correlate with a response to injection. Some authors have tried to say if you do a composite, if you have 6 or 7 different tests and you sort of do them all and people have a number of them, they may be more likely to have SI joint pain. I think one of the better studies was by Dreyfus et al. In 1996. And what they found really I like this quote. No historical feature, none of the 12 SI joint tests, and no ensemble of these tests demonstrated worthwhile diagnostic value. It's a fairly strong statement. I think the best you can say about physical exam and SI joint pain is that by where somebody hurts, whether they're tender of the SI joint, what else you may see in an exam, you can keep SI joint pain within the diagnosis. You can't diagnose it. You can just sort of say maybe it is. We get into imaging to help us with diagnosis, a number of different choices. We've been through some of these this morning. Plain radiography, CT, MRI, nuclear imaging, bone scan, SPECT. This is an MRI of a lady who came into my office about a month ago with severe left buttock pain running down the back of her leg, normal lumbar MRI. And this is her pelvis MRI, stir sequences. And she has edema on the SI joint on the left side. And she did extremely well with an SI joint injection. The trouble we have with imaging in general for SI joint pain, however, is kind of like physical exam. There's a very poor correlation with diagnostic imaging and the response to injection. So if we look at injections, again, as a diagnostic tool, we'll talk about it therapeutically in a little bit. We have if you use a single block protocol, injections are not overly reliable, about a false positive rate of 20%, which is actually lower than you see for facet joints, other things that may be higher than that. With a double block protocol, you may get better results in terms of diagnosis, but some question of validity even of a double block paradigm. And part because of this is a study by Fortin where they injected 76 SI joints, looked at the arthrogram, and 60% of them extravasated. So the dye went anterior, went posterior. It did not stay in the joint. And this is an MRI with gadolinium in the joint, showing anterior extravasation of gadolinium that really approximates the lumbar plexus. So you may numb up a lot more than the SI joint by putting anesthetic in a joint like this. So diagnostically, how much does it help you if all the pain goes away? Treatment, we have several concepts on non-operative management. If you talk to therapists, you talk to non-operative providers, this is what you hear. Reduce inflammation, treat pain, normalize mechanics, a fairly vague term, establish and optimize appropriate lumbopelvic stability, address lower extremity mechanics, so orthotics and all sorts of other things, and address underlying contributing factors. This gets into the SI joint as a victim. This is a patient whose SI joint I injected, but if you look carefully at their hip, they have OA of the hip. There's some thought that sometimes the SI joint really is a victim of a problem elsewhere, such as a hip problem or even a fusion across the sacrum. Treatment, number of options have been proposed for treatment: manipulation, exercise, lumbopelvic stability is particularly popular lately, orthotics, lifts, SI joint belts, and then injections and radiofrequency neurotomy. The trouble with all of this is that there are a lot of problems with the evidence and the data. First of all, if you start with establishing the diagnosis, it's very hard to do. All those other studies really get into a very low prevalence, complications with how you diagnose it, do you use a double block protocol or not. Even if you do manage to diagnose it, you have a very mixed group. You have idiopathic people, postpartum, the spinal arthropathies and traumatic or etiologies, and they're probably not all the same, and treatment options probably aren't all the same. If you look at the spinal arthropathy data, there are several small non-controlled studies. There's one small randomized study on peri-articular injection, so just in the ligament around the joint, not in the joint, and one small injection on one small study, intra-articular injections. And truthfully, the general trend of all these studies is that the results are generally favorable. If you look at injections in the general population as a whole, there are two systematic reviews of SI joint procedures, one from Mackenzie Brown et al. In 2005. They found in their review of all the data that there was moderate evidence for short-term relief from intra-articular corticosteroids and really very limited evidence for long-term relief. And another more recent one from Hansen just came out this year. Again, very limited evidence for the therapeutic use of SI joint injections. So we don't have a lot of data to support that they are helpful. In fact, the Hansen study, the only RCT that met their criteria had 10 patients in it. I imagine for what most of you do, you really don't like to hang your hat on one study with 10 patients to say this is what you should be doing. So radiofrequency neurotomy also being used. This is really a problematic issue, I think. There are a number of small studies with very inconsistent results, some positive, some negative, some middle of the road. A lot of issues with it, some significant differences in technique, how they do this, where they do this. There are issues clearly of patient selection. Again, you get that diagnostic issue, who has it? And how do you decide who has it so you can decide whether you're going to run a trial of treatment on that? The anatomy innervation issues clearly are an issue. We really don't even have a consensus as to how the joint is innervated. So then how do you go about denervating it? Small problem. Technical issues in terms of how you do it. And again, the therapeutic evidence really is limited. Both those systematic reviews came to the same conclusion. So in conclusion, personally I think isolated SI joint pain is relatively uncommon. I think the data supports this. I think it is a relatively uncommon entity. I think physical exam findings are really not reliable in establishing the diagnosis. Imaging findings don't correlate well with the response to injection. Injections may be more helpful when you really have a sacroiliitis, ankylosing spondylitis, something similar. The injections may be more helpful. And when we look at all our data, there really is very limited data for our treatment options, including injections and what we do. And that is it. Thank you.
We have Ray Baker here, anesthesiologist. He's going to talk about the synovial cyst and recent insights.
Thank you, Rick. I'd like to also thank Synthes as well as Drs. Chapman and Chestnut for inviting me to speak with you today. The first cyst was described by Baker in 1885 at St. Bartholomew's Hospital, and obviously it was part of an operative finding. Now with advanced imaging, CT, MRI, we're able to look at these preoperatively as well as in patients that we might find an incidental cyst or do medical management. Here's a case from Curtis Slipman of a L4-5 facet cyst on the right, and you can see it on the sagittal cuts on the right side of the screen. They're a little bit hyper-intense on T2 weighted images, as they often are. First, a little bit of terminology. I suppose we should really call these lumbar juxta-articular cysts because they come in three types, really: facet cysts, ganglion cysts, and ligamentum flavum cysts. More people now are lumping them together and saying that we're artificially drawing boundaries, and they probably all three are different manifestations of the same entity. So less time is being spent on trying to subclassify these now. In terms of etiology, although quite a bit of time has been spent looking at the metaplasia and proliferation of rests, more time now I think is being spent on the fact that these might be a herniation essentially of synovial tissue through a capsular defect. I think it's important when you look at etiology of effusions in the facets as well as cysts to look at the Kirkcaldy-Willis cascade. I think it's instructive, and we'll see this over again through the talk. Phase 1 is the early phase of dysfunction in the discal ligamentous structures with minimal anatomic changes. 2 is relative instability with decreased disc height, loosening of the facet capsules and ligaments, and the beginning of some abnormal translation and rotational motion. It's important that most of the effusions occur in this setting and most of the cysts occur in this setting. Phase 3 is the restabilization phase where the disc height lowers further and you get osteophyte formation and fibrosis with relative stability. When we look at associations then, it makes sense that these conditions are associated with lumbar facet cysts, facet arthropathy, degenerative spondylolisthesis, facet effusions. It also makes sense from that same cascade that there's no association between the grade of disc degeneration and the formation of cysts. Looking at the epidemiology a little bit, they represent probably about 0.5% of patients presenting to a clinic for pain. It's most commonly at the L4-5 segment, and that makes sense because that has the most motion of any of the lumbar segments, and usually is found in patients in their mid-60s. When we look at the presentation, although they can be asymptomatic, most people will present with radicular pain. You can see that clearly more than half the people presenting will have radicular pain. They might have neurogenic claudication, especially if you get growth centrally in encroachment of the spinal canal. They can more rarely present with a Cauda-Equina syndrome, especially with a rapidly growing cyst, as you would see with hemorrhage, especially with spontaneous or traumatic hemorrhage. And over half the people have preceding low back symptoms. In terms of diagnosis, MRI is the preferred method for imaging, and you'll often see the nature of the cyst as well as its relationship to the thecal sac, which can be important if you're going to want to reduce the incidence of dural tear. And they're often hyperintense on either T1 or T2 weighted imaging, although that's not always true. The use of gadolinium will increase the sensitivity because the cyst capsule will enhance. Salmon looked at the sensitivities of MRI versus CT versus myelography alone, and he reconfirmed the fact that we would all think and that is that MRI was the most sensitive tool for detecting cysts, followed by CT, and followed by myelography alone. CT arthrograms are uncommonly done, but they can verify a cyst if it's unclear. And this is a case from Charlie April that was published as part of a case study. You can see on the left-hand side the MRI, and on the right-hand side the CT arthrogram. The medical management varies, everything from no treatment at all and just observation all the way up through cyst punctures. There is a paucity of good data in the medical literature and in the surgical literature. Most of the papers are either retrospective case series or case reports. We have no prospective series on these. So we have a hard time getting any really good handle on what is best. But when we look at the interventional treatments, such as cyst aspiration, injection of steroids into either the facet cyst or into the facet itself, or nerve blocks or some combination of that, 3 papers would show that the benefits are between 29 and 44% of patients reporting either good to excellent results up to a year out. It surprised me a little bit because my experience has been that it's less than that, that I think that fewer than 30 to 45% of patients will have longer term improvement, although certainly you will see occasional patients do quite well. It's important to know that over half the patients in all 3 of these series had surgery, and that really is probably the most common. Now, I had a patient referred to me last week, and it was very interesting, from a local orthopedic surgeon with left L4 radicular symptoms and an extraforaminal or foraminal cyst. And I was asked to rupture the cyst, which I have not done in a long time. I would not rupture it if it were within the spinal canal, because I don't like to have an expansile cyst in a closed bony area. So I would not do that, but this was extraforaminal, or at least foraminal, and I felt more comfortable as long as the patient was awake. You can also see incidentally in the red arrow a dorsal facet cyst on the right that was asymptomatic. So the first thing I did, and you can see the top 2 pictures, was to place a needle in the dorsal inferior capsule of the facet and fill the facet and thereby fill the cyst. And you can see the yellow arrows are the cyst. I then took a secondary needle, and that's the bottom 2 pictures, and went into the cyst itself. Then I injected contrast, and in a retrograde fashion, you can see it fill the zygapophyseal joint on the top right picture, and I monitored the patient for leg pain. He had no leg pain whatsoever. He had increase in back pain. I put some Marcaine in, that went away, and I put 2 more cc's of contrast. And you can see on the left-hand side that the cyst ruptured dorsally out of the inferior capsule, but on the right-hand side you can also see that it ruptured just next to the cyst itself. How this patient will do will have to wait to be seen, but certainly anecdote is not evidence, and we need better evidence if we're going to say that one treatment is better than another. Now let's move on to surgical management. 2 types are most commonly done. One is the decompression with cystectomy and usually a partial facetectomy, versus that same surgery plus effusion. And most times those are the patients with a degenerative spondylolisthesis that are either unstable or you're wanting to try to prevent instability. There's a number of papers on this. All of them are retrospective, and I took 2 of the larger and more recent series to look at. Both of them show greater than 90% improvement. The top was in self-reporting, the bottom was on modem, but certainly the patients did well with a cystectomy and or fusion. And the Kahn study, interestingly, from 2005, supported that in those patients, the people who had fusion actually had a better self-reporting than the patients who did not have fusion, with 80% saying they had good to excellent results if they had fusion, where only 70% in the patients who did not have fusion. Complications include the incidental durotomy in 3 to 9% of the series that I reviewed, recurrent cyst in about 3 to 5% of cases, and instability requiring fusion in 3 to 9% of cases if they were not fused at the time of initial operation. More interesting to me, and something I want to spend about a minute or 2 on, is effusions. And this is where the recent insights, I think, have come. Wren and Chaput both published papers in 2007 in Spine on the degree of effusion in the facet and relative instability. And what they both showed was a linear correlation. Wren, in this study, looked at what he called the facet fluid index, the width of the effusion divided by the width of the facet at their maximal points. And indeed, 23 of 28 of the patients that he operated on with effusion also had instability, where only 4 of 23 of those patients without effusion had instability. And here's the Pearson correlation coefficient of all those patients, showing a linear relationship between the amount of effusion and the slip at L4-5. Chapman also published a paper this past year with similar findings. 30% of the patients with 1 millimeter of effusion had instability versus 60% at 2 millimeters of effusion, and a full 85% of the patients with 3 millimeters or more of effusion had a slip. One of the more interesting findings, and I'll leave you with this, is that in the Chapman paper, almost a quarter of the patients had normal supine lumbar MRIs. And interestingly, those patients on flexion extension films had spondylolisthesis, and those patients had larger effusions on average than the patients who showed up on MRI as having a slip. They recommended ordering flexion extension films on all patients with degenerative spondylolisthesis on MRI and those with more than 1 millimeter of effusion. I'll leave it there. Thank you.
Really, in fact, we're talking about degenerative spondylolisthesis with stenosis, so I tend to call it DSS. And this is what's really common in all of our offices. This is what's common to everyone who deals with the lumbar spine conservatively or surgically. And it turns out it's a history lesson because it keeps going around and around. And if you go way back, you know, nobody operated on the spine until 1914 for anything really, and that was effusion for TB. And then Mixter and Barr certainly made the Americans aware of discectomy for sciatica. And then there was a long time between about the mid-50s, really 50s through 60s, where people started to do very radical laminectomies. So there became a response, and at Mayo Clinic they responded by doing laminectomy and effusion on every patient. And then there was a history of casting and bracing. Really not until 1960 did Paul Harrington bring up the American movement toward instrumentation. And between, again, the Mayo Clinic experience went on for almost 15 years. And then there was a general, by 1970s, there was a Wilsey effect. And Wilsey, who had defined and worked hard on spondylolisthesis, had a general statement that if you were under 60 and the facets were resected, you need to be fused. And if you were under 55, even if you had central decompression, you should be fused. So remember, just for a moment, that we have the central laminectomy, and we have an exposure of the dura. And then we have one in which the facets were removed. So then you come to a more radical laminectomy. So these got confused also in this history, because now that we're talking about minimal, what was minimal was something less than either one of these. So we have to recognize, again, the history. I only bring this up because this probably the only important part is that when he looked at the results, he had an arthrodesis group that looked much better. They had 11 excellent and 13 good and none poor. And if he looked at the no arthrodesis group, he had a predominant group that were fair or poor. So then this is an article that's pretty much up to date, 2001. It's Christensen, and this is the Norwegian study, or the Scandinavian study. And this is looking at the 5-year outcome of pedicle screw fixation versus non-instrumented fusions. And what they find out is that about 70% of patients, done either way, had some global satisfaction. But again, with the pedicle screw instrumentation, you improved the overall studies. But both of them work. This is a review of the main study. So he looked at 148 patients with this degenerative spondylolisthesis and stenosis. And there was really a 56 and 41 groups that went into surgical treatment and non-surgical treatment. And the conclusions from this 10-year, quote 10-year article are that low back relief was the same in both groups, but long-term leg pain relief is better with surgical treatment. I doubt whether this is a helpful article. Sean Nork, he wrote this, and this was the outcome of lumbar decompressions and fusions. And these were 30 patients, greater than 40 years old. 93% were satisfied. And the conclusion that there was a 93% fusion rate in that same group. That led to a response by Herkowitz. So Herkowitz keeps coming up. And Herkowitz now says that the outcomes from the decompression and fusion are better than, is a better way to treat degenerative spondylolisthesis. And he goes over the history of what's going on before, and then he quotes Nork, looking for that outcome study. And so the conclusion is that we now have a procedure that is equal to, in outcome, to joint replacement and to coronary bypass, two well-known successful procedures. And he says, in conclusion, that the burden for those advocating limited surgical management for degenerative spondylolisthesis stenosis will need to have their own prospective studies with unbiased observers. So he's encouraging them to go and do the whole study over again for those patients. So my question is, this is a 70-year-old woman with back pain, anterior thigh pain when she tries to walk. She's quite disabled. I like to make it further that this is your mother-in-law and you like her. All right? So go back. So what I want to ask is, if you like this person at 70 years old and you'd read all the literature, the question is, what should she have? And I think the literature is swinging that this person has a potential to become unstable if you're not very careful with your laminectomy, especially not being very careful in a laminectomy with someone who may have risk for osteoporosis. But what I've really learned out of going over this study is that it takes 10 years to prove you're wrong. I thank you.